Okay, now we are going to try to show you the setup actually. I will leave the floor to Professor Emrah. He's going to tell the process of a US biopsy, and then I'd like to thank Chisel. She has a meeting in Ankara, but she did her best to be here. After the meeting, she's going to go to Ankara, thanks to her efforts making this meeting better. And now this is the setup, Professor Alper helping us. And now I leave the floor to Professor Alper.
Şimdi bu hastayı biz Gürkan'la yaptığımız sonradan da sunacağımız bir vaka aslında bu. Bu vakanın en önemli özelliği çok küçük bir IPMN olması ve operable çıkması. Bu hastada biz çok heyecanlı bir şekilde yine böyle Gürkan'la beraber bakarken bu hasta Gürkan'a başvurmuş. GGT yüksekliği 1000 civarında bir rakam. Başka bir şey yok hastanın. Dilate pankreas kanalı, dilate kolodok.
Can we do it like short translations? This is a patient will be discussed in the detail in the afternoon session. The only finding was GGT elevation. We will discuss in detail. And now the patient was referred to our outpatient clinic, and we were planning to perform an EUS biopsy. Now Professor Alper is evaluating the patient.
Bu hastada heyecanlanmamızın sebebi gördüğünüz gibi aslında çok küçük bir alanda pankreas kanalının içinde bir şeyler vardı. Ve bu şöyle hayal edin. Bunu ampulleyi kestiğinizi farz edin. Daha sonra Volkan hocalar da gösterir. Ortak kanal içinde bir sorun var. Ortak kanaldan da pankreas kanalına gidiyor ve bu boyut 5 milimetre. 5 milimetre ama görüntü EUS görüntüsünde biz o papiller yapıları görebiliyorduk bu hastada. Yani papiller yapının şu anda görüyorsunuz pankreas kanalındaki papiller yapılar şunlar. O kadar küçük bir alanda çalışıyorsunuz ve bir tek şansınız var bu hasta için çünkü çok küçük. Hollywood'daki delip geçiyorsunuz, ampule de deliyorsunuz. Onun için tek bir şansımız vardı. Bu hastayı opera edelim mi etmeyelim mi diye. Başka hiç invazyon yok. EUS'ta nadir görürüz ama bakın şuradaki pankreas kanalının ekojentesini bile görebiliyorsunuz. Fibrotik ekojentesini. Yani hiç kanalın dışına da çıkmamış bir lezyon. Böyle tanımladık biz. Daha sonra biyopsimizi aldık. Bunun devamında patolog sağ olsun hocalarımız geldiler. FMB iğne kullandık. FMB iğne kullandık. Çünkü doku elde etmek istiyorduk bu hastada. FNA'yı de kullanabilirdik ama sadece hücre elde etmek daha istemediğimiz bir o dokuydu. IPMN düşünmüştüm ben bu hastada. Pankreas kanalı kökenli bir IPMN düşünmüştüm. Görüntü olarak da çok erken evre diye düşünmüştüm.
Now this patient was a patient with elevated GGT, and Professor Alpo was thinking that this might be a case of IPMN, and there was a papillary lesion in the ampullary area which goes on in the pancreatic duct, and it was quite difficult to get a biopsy sample because the lesion was so soft. That's why he used FNB needle, and in these cases, what Professor Alper tells us that you have only one chance to get enough sample. Most of the time, as Chisel told, we pass many times to have enough samples, especially in those cases who are not operable. We are trying to get more samples as more as possible for molecular studies as well. In this case, we had one chance. He used FMB needle.
Takiben bu hastada biz FMB needle'ın devamında göreceksiniz zaten. Hareketlendirebilirsek. Tekrar lezyonu görüyorsunuz. Artık ekranda daha ayrıntılı görebilmek için diğer kesitsel IPMN'deki o villöz yapıların görüntüsü bu. Tabii çok büyüttüğümüz bir lezyon. Örnek yine biraz daha ilerletebilir miyiz? İkincisi olabilir. Bunun devamı var mı? Evet. Burada FMB iğnenin içinde aldığımız örnek hafif sıvı geldi. Pankreas sıvısı geldi içine bunu doğal olarak. Şurası gördüğünüz üstteki koleodok. Şurası ampulle aslında. Şu koleodok, şu pankreas kanalı işte IPMN diye düşündüğümüz yapıda o ortak kanalın içinde. Ampullenin içinde. Takiben o hazırlıklarımız başladı. Patolog hocalarımız geldiler. On-site biz çok şanslıyız ki bize çok yardım ediyorlar. Artı çok da deneyimli bir stopatoloğumuz var. Stopatoloji teknisyenimiz var. O kadar ki bize camları yayarken bunda malign hücre var, bunda yok, burası iyidir falan diye yayıyorlar. Bu bizim için mükemmel bir şey. Hani hatta iddiaya giriyoruz hocam işte hatta iddiaya giriyoruz işte hamburgerinizi alırım falan hocam. Bu adene bu nöron döküm falan gibi o kadar iddialı konuşabiliyorlar artık. Gerçekten dokuya bakarak.
Now, this is the part that we want to share you the technique. After finishing the biopsy procedure, we get the samples out. We have a cytotechnician. He's very experienced, really. I have seen it many times. He, just a second. Okay. He's checking the sample before our pathologist comes to the endoscopy suite. The cytotechnician always says it seems enough. And now, after getting the sample out of the needle, they start for the process.
Tıp fakültesindeyken böyle cama bakardık da öyle söylerdik 3. sınıftayken. Makroları ona göre şey yapardık. Sınava. Aynen öyle oluyor. Kaldırıyor hocam burada var falan böyle yapıyorlar. Evet.
May I add something about that? I already mentioned about macroscopic on-site evaluation. Actually, it has been widely using around the world, and they have published cases about that. How can we obtain enough material with just macroscopic on-site evaluation? And it's just for the FNB, by the way. It's not good for the FNA samples. But of course, the most important thing in this video is he is dissecting the particles. This is the most important thing. And Dr. Fırat?
Oh, that's okay. I mean, of course, we have a judgment when we look at the particles, and it is a macroscopic evaluation as we do on the gross specimens. So we can understand if it's white, we can think about something. If it's mucoid, we can think about that it's non-diagnostic. It's okay. However, the main thing, as Giselle says, just to take out the particles on that side, leave the blood on that side, and just squash one of those particles to see the morphology and keep the others for the cell block. And of course, in time, you get an experience to judge whether this tissue is enough or not.
Evet.
But I mean, it's not that easy. I mean.
Şu anda işte ekranda görüyorsunuz. Biraz önce Çiser Hoca'nın size bahsettiği gibi. Orada bu konuşma olsaydı duyacaktınız ekranda. İşte şöyle küçük küçük ayrıldı. Şudur budur diye şey yaptık. Ondan sonra bu aldığımız sıvı, işte pankreas sıvısı da geliyor doğal olarak o kanalın içerisinden o sırada. Sıvıyı da yaydık. Takiben boyama aşamasına geçeceğiz. Bunu biraz hızlandırabiliriz burada. Burada bir ayrımı gösterebiliriz. Çok küçük ince şeyleri. Vakit kaybetmemek adına. Evet, şöyle doku ayrıldıktan sonra içinde şu şekilde en küçük partikülleri görmeye çalışılıyor. Ondan sonra gerçekten işte telefon lambasını falan tutuyoruz. Bir şeyler yapıyoruz orada. Orada hani beyaza yakın doku neymiş diye ayırmak için. Ondan sonra stetokrinolog arkadaşlarımız onu ayırıyorlar. Hocalarımız ön hazırlıklar yapıyorlar. Biraz önce Çisel'in bahsettiği gibi. Daha sonra bir kısmı boyama için ayrılıyor. Burada gördüğünüz işte 3 boya artı bir tane de solüsyonumuz var temizlik için. Fiksasyon solüsyonumuz var. Boyamalarımız var. Şu biraz önce gördüğünüz şey, bu tabii cerrah anlatmak bunu çok böyle mantıklı değil. Ben bunu kongrede anlatsam bizim kongrede çok daha efektif olur. Çünkü en büyük sorunumuz bu. Biz size biyopsi alıyoruz ama sonuç veremiyoruz. Bunun bir anlamı yok aslında. Rapid on-site histolojinin bize en büyük avantajı bu. Gastroenterologlar aslında biz mikroskopi bilmiyoruz doğal olarak. Yaymayı da eğer yapamıyorsak o giden materyal patolojiye gidiyor. Ve patolojiden de genelde sonuç non-diagnostik geliyor. Bu iki sebepten bir, biz kötüye hep göndermiş olabiliriz ya da almışızdır. İki, patolog bilmiyordur. O da olabilir. Türkiye'de pek çok merkezde stopatolog olmadığı için özellikle FNA alıyorsanız aldığınız FNA'den sonuç elde etme oranınız düşük. FNB biraz daha doku parçaları falan getiriyor. Daha tanıdık geliyor patologlara, histopatoloji çok da hakim olmayanlara. Bazı üniversitelerde çok da sevdiğimiz dostlarımızın yaptığı, abi ben 10 defa biyopsi alıyorum hiç sonuç gelmiyor falan gibi böyle ifadeler var. Burada 10 kere de yanlış sonuç almak bir eğri için kolay değil. Mutlaka arada bir şey tutturursunuz yani. Ama muhtemelen patolog dostlarımız çok hakim olmadıkları için yeterli sonuç vermiyor olabilirler. Bu da size geri dönük olarak cerrahiye, ya da bize hastadan geri dönüşler hoş olmuyor. Özellikle bunu özel bir hastanede yapıyorsanız bu çok daha kötü bir şey. Çünkü hasta bir kere bir ücret alınmış oluyor. Sonra hasta olmadı bir daha gelin bir daha falan, böyle bu gerçekten hoş olmayan bir durum. Maddi anlamda, öbür türlü hastaya zaten yük. Normalde devlette de çalışsanız bir yük. Daha sonra burada bir...
Just a brief, actually, Professor Alper says this major issue in any center who performs EUS without on-site pathology, the way you, as the Chisel has previously shown, the optimal technique to get an optimal view of this sample and saying that it is okay, enough sample we have retrieved, is the major issue in EUS biopsy. Because if you don't have on-site pathology, you finish the procedure, and then after a couple of days, the report comes back. We cannot say anything, non-diagnostic sample. That is the major problem in this process.
Bizim çalışmalar ve guideline'ler diyor ki 3 defa gelin bırakın. Ya ben 3 defa değil, işte Çisel burada. Evet, 15.de.
And but because of this is the even in the resection specimen, it's the tumor is highly how can I it's invisible.
Yeah.
Therefore,
yani pankreas kanserleri fibrotik. Biz girdiğimizde bir hattı kullanıyoruz. Bir hayal edin. Şöyle bir top var. Elinizde 5 santim ve bir iğne var. Bu iğne incecik bir şey. Bu iğneyle şu topa biz şuradan bir vuruş yaptık. Sen daha iyi biliyorsun pankreas kanserinin sertliğini falan. Buradan aldık boş 1. Buradan aldık boş 2. Buradan aldık boş 3. Arada bir sürü doku var. Bir portakalın olacak. Çok küçük bir alanda örnekleyebiliyoruz baktığınızda. Ve bizim gayettenler diyor ki 3 defa al. Ya bu 3 defada o hücreyi yakalamak gerçekten bazen olmuyor. 15'de yakaladığımız var. Ortalama 8-9'lara gidiyoruz bazen. Hadi bir de bu değişti. Şimdi bizim inoperable hastalarınız var. Çok. En şanslı grup pankreatobiliyerciler. Çok hep inop hastanız var sizin. Kolorektal gibi değilsiniz yani. Oradan aldığınız doku da sizin artık moleküler çalışmamız gerekiyor. Onkolog istiyor ki ben moleküler istiyorum. Ya ben kardeşim zaten şu kadarcık bir şey almışım. Sana nasıl vereceğim? Benim derdim bu. Nasıl vereceğim ben bu dokuyu? Onun için sayıyı arttırıyoruz. Sayıyı arttırdık, bu sefer başımıza başka işler çıkıyor. Kanıyor hasta. Yani ben her iğneyi soktuğumda bir yere aslında dürtüyorum. Özellikle nöroendokrin ise tam baş belası. Bir hastamız var. Hastayı 12 hemoglobinle soktuk, 3'le ölümden döndürdük zar Barbaros sayesinde. O kadar kanıyor. Neden? Patologlar sağ olsun yetmedi abi. Yani o öyle bir şey.
We have a question from the audience.
Really, I missed something. That's my bad. Well, we have a patient, cystic lesion, possibly IPMN, 5 millimeter, and we have only finding upper level of GGT. So, what's the main indication for EUS biopsy?
The only finding is GGT elevation and pancreatic head cystic lesion.
It's 5 millimeter, possibly
yes.
It's IPMN. So why are we taking biopsy?
Well, do you have any other imaging?
Well, why don't we follow the patient?
Bu hastanın pankreas kanalı da dilateydi, koledok da dilateydi. MRCP'de diyordu ki...
If I miss, that's my bad.
Sorry, you were asking about this. This patient, GGT was 1000 and...
Only GGT.
GGT, yes. Alkaline phosphatase, cholestatic enzymes were elevated, plus dilation, plus MRI findings clearly demonstrated a problem in the distal bile duct, and there was something we have detected in the MRI, which
consistent with IPMN?
No, not IPMN. There was a lesion. We had to clearly identify what that lesion was. There was obstruction. That was the issue. I think about the setup of the pathologic evaluation, endoscopic ultrasound biopsy is clear. Maybe proceed for the... We would like to discuss two brief cases. A 62 years old female. She had an abdominal pain, and ultrasound detected a pancreatic head cystic lesion. And now I would like to, this patient was referred to our center for EUS. So Professor Alper have taken the patient to endoscopy suite, and I would like to listen him about his finding.
Bu hastanın aslında sadece ultrasonu yoktu. Tomografisi de vardı. Ama yani ultrasonda MR'ı vardı ilk başlangıçta.
Yok, senin EUS'undan sonra MR çekilemez.
Şimdi bu hastanın biz girdiğimizde şu kist için girdik aslında. Oradan da örnek aldık. Bu gördüğünüz kistin bizim EUS'taki görüntümüz nasıl? Bakın standart bir kistten biraz daha farklı. Bir duvarı var. Yani bir duvar kalınlaşması görüyorsunuz. Normalde kistlerde şöyle bir kalınlaşma genelde görmeyiz. Yani burada bir stroma var gibi duruyor görüntü olarak. Tek bir kist, anekoik, normalde septasyonları da yok, çapı da yaklaşık 2 santim falan. Normalde bunu gördüğümüz için biz biyopsi örneği aldık. Buradan sıvı gönderdik. Bunun sıvısında CA'sı 19.000, CA'sı 12, 1200, 1500 falan gibi şeyler geldi. Ama ondan önemlisi, biz bu hastada o işlemi yaparken şöyle bir lezyon da gördük. Kuyrukta. Bir o baştaydı. Hani biz buraya bakarken bunu da gördük. Ben de dedim ki o 4/4'lük seröz kistaderom bu. Bizim kitaplar öyle yazar. İşte böyle süngerimsi bir yapı. Ondan sonra elimizde tabii bir kontrast enhancement yok sonovu gibi. Ama biz öyle ayak yapıyoruz işte aletle biraz damarlandırıyoruz falan burayı. Ya dedim bu tamam. Seröz kistadenom çok da güzel görünüyor. Raporuma da seröz kistadenom diye yazdım. Pankreas başta kistik lezyon, kalın duvarlı, müsinöz, neoplez soru işareti diye yazdım. Buna da seröz neoplez diye yazdım. Daha sonra bunun patolojisi geldi.
Now, just a brief of the case. The pancreatic had cystic lesion. Professor Alper had performed a biopsy and the fluid sample retrieval from the pancreatic head lesion, but at the same time a pancreatic tail lesion, which from the point of endoscopic ultrasound, Professor Alper clearly thought this is a microcystic serous cystadenoma. Everything was compatible with that diagnosis. And after having the biopsy sample, the day he performed EUS, we performed an MRI.
Ben şimdi bu raporu yazayım.
This is the fluid analysis.
Yes. O aldığımız sıvının örneği de buydu. Bunu da kısaca üstten geçeyim. Yani sizi ilgilendiriyor mu bilmiyorum ama bizi ilgilendiriyor. Muhtemelen sizi de ilgilendiriyordur. Böyle bir sıvı aldığımda pankreas sıvısı içerisinde biz mutlaka şu 4 parametreyi gönderiyoruz. Önceden glukoz yoktu. CA19-9 da yoktu. Sadece bu ikisi vardı. Genelde bu ikisi gönderilirdi. Artık biz 4'lü gönderiyoruz panel gibi. Bu yapabilsek KRAS, GNAS da göndermek en uygunudur. Ama genelde o kadar materyal çıkmıyor ve fiyat çok pahalı. Onun için baktığımızda bu hastanın CA'sı 12.709 geldi. CA19-9 10.000'in üzerinde. Yani onkosolik mukus salgılayan hücrelerin salgıladığı içerik. Glikoz 4 canlı hücreler var anlamına geliyor. Tüketiyor o sıvıdaki glikozu. Ve amilazda kanalla ilişkisi yok. Yani şuna baktığımda ben 4/4'lük müzinöz neoplazi zaten diyorum şu sonuçta. Ve daha sonra bu hastanın patolojisini de Çiser Hoca bahsetsin.
Is it possible to use cursor because online audience cannot follow marks?
Sorry. Can I get the question again? Is
it possible to use cursor? Yeah.
Okay. When we look to the, this is from the cyst fluid, and we perform cytospin preparation for this. Even you can see in here, there are some, in the background, there are some necrosis, and there are some highly atypical cells during in here. And you can see in here, we have few cells. When we look here, the nucleus cytoplasmic ratio increased, but we are not able to see the details of those cells. Those can be histiocytes.
No, it's okay.
Okay.
No problem.
And when we look to the other, it's really hard to obtain those images because it's really hard to find those cells. We have this highly hyperchromatic nuclei cells, and especially for the necrosis, you can see those are like the ghost cells, like they can be a necrotic cell debris, or they can be histiocytes. We are not able to show the characterization of those cells, and we diagnose this as like the highly atypical cells with the necrotic debris, but those cells are really suspicious for poorly differentiated carcinoma. Do you want to add something?
So for a case like this, there are really very minimal material to move on. So I just want to say that the joke that we have among ourselves in the department is we're walking with a guillotine on our head because we call these things carcinoma based on these cells. One of these days, that guillotine is going to cut our head because there's going to be a false positive. And we try to avoid that false positive, but it's kind of a concern that we always say. Another joke I have is, yes, we call this carcinoma, let's start praying that it is, not of course for the patient, we hope it's not cancer, but let's hope we are right. And in this case, actually, the radiology will be presented.
Burada ben bir devreye gireyim. Bu kisti hayal edin yine. Yaklaşık 2 santim çapında bir badem gibi bir şey. Bunun içi sıvı dolu ve biz tek bir noktadan bir iğneyi yine bir yere sokuyoruz o bademin içine. İğneyi tek bir hamlede kullanmak durumundayız. İçeriği enfekte etmemek adına ikinci şansımız çok olmaz kistlerde. Sıvıyı çektiniz, tahlile gönderdiniz. O arada duvarı tek bir noktadan şu şekilde hareket ettirerek hasarladınız. Bu hasarladığınız dokuyu da patolojiye mümkünce kanlı şekilde göndermeniz gerekiyor. Tek bir nokta. Şu hale bir alanda ben girdiğimde buradan alıyorum. Bunun geri kalan duvarı hakkında hiçbir yorumum yok aslında baktığınızda. Onun için biraz önce hocanın dediği de o. Yani aslında giyotine verilmesinin sebebi bu şöyle bir şeyde tek bir şu noktadan aldığımız örnek üzerinden bir tanı koyarak siz bu hastanın geleceğini belirlemeye çalışıyorsunuz. Çok zor bir şey aslında. Patologlar için de bizim için de zor bir şey. Evet, bu hasta daha sonra bu arada gireceğim. Ben bunda tomografi çektirdim. Benden sonra MR. Dedim ki ya
Emre, önce senin EUS yaptığın gün MR çekildi.
evet, MR. Onu söyleyeceğim, gelecek sonuca. Ben bunu çektirdim çünkü bu kistin arkasındaki seröz kist neydi diye. Baştaki tamam, onu biliyoruz. Ama ben kuyrukta bir şey gördüm. İçim rahat etmedi, radyolojiye gönderdik.
Here you can see the MRI on the next day, I think, after EUS and aspiration. There are two distinct lesions. Well, it's very hard to comment about the lesion at the head portion, unsnake process. This is a bright lesion, so this looks like there's fluid inside. This may be cystic, but it is tubular. So I wouldn't call this a cyst. This looks like a dilated duct, maybe because you aspirated it. So I won't give a differential diagnosis, maybe ductal dilatation or an IPMN, but I cannot see the ductal communication because I cannot even see a cystic structure there. I wish to comment about the lesion at the tail. Normally, you know that pancreas has outer lobulated contours, and at the tail portion, this contour lobulation is lost, and there is a mass lesion, an apparent mass lesion at the tail of the pancreas. This is the arterial phase after contrast administration. So there is arterial hyperenhancement in this lesion. I would go for a neuroendocrine tumor of the pancreas, PNET, but the endoscopist said this could be a microcystic SCN. Sometimes microcystic SCNs in the honeycomb variant also seem to enhance with contrast. So it's hard to differentiate in between, I think, in this case. But this didn't have cystic intensity on T2 weighted image. I didn't see any fluid intensity in this lesion. So I think the first probable diagnosis is a PNET at the tail. I cannot comment about the cystic lesion at the proximal part of the pancreas.
That's the 1 month computer tomography finding.
CT was performed after 1 month after this MRI. Now I can really see a cystic lesion at the unsnake process of the pancreas. When you look at the lesion, it has well-defined borders, somewhat heterogeneous in the center. It looks like there are a few cysts inside, and we didn't see any ductal communication, but it is harder to see with CT. I would prefer to see an MRI. So this looks like a post-C locular cystic lesion with no ductal communication. Should I comment about differential diagnosis or? This doesn't look like an IPMN. I don't see the bunch of grape appearance and outer lobulated contour. This could be an MCN, SMC, scope maybe, but in case of scope, they are mostly unilocular. I don't think this is a cystic peanut because there is no contrast enhancement at the wall of the lesion. These are my possible diagnosis. And again, we saw the same enhancing solid lesion at the tail of the pancreas, looking like a cystic peanut. Peanut, excuse me.
Okay, now that's the retrospective analysis, of course. But when we have these imagings, and Professor Alper performed this endoscopic ultrasound, he clearly decided about microcystic cystadenoma. So because of this atypia found in the head of the pancreatic cystic lesion, we go for treatment, for the surgical treatment. We decided to go for, can we come back one slide? Now, so we have two problems, one in the tail, which is supposed to be, might be a microcystic cystadenoma, and plus we have an pancreatic head cystic lesion with significant atypia. And during the operation, I called Professor Barbaros. He came and we made a biopsy for the pancreatic tail lesion. It came out neuroendocrine tumor. And we aspirated the cystic lesion because then the strategy changed. Ayşe was with us. She's here now. And she said, this seems completely benign, but there was a significant atypia preoperative EUS biopsy. So we called Professor Adsay. We made a huge discussion. And at the end, we decided to go for a total pancreatectomy after discussing with the relatives of the patient. And now floor is Professor Adsay's.
Yeah. Professor Tellioğlu is making it a little bit softened and nicened now. During the operation, the conversation was going like this. You called this carcinoma. I'm going to do total pancreatectomy. Are you sure? Now you are calling it benign intraoperatively. What am I supposed to do? It was, we were sweating, all of us. But joking aside, yes, there was a neuroendocrine tumor. And this is the cyst. This cyst has actually some interesting academic angles. It is a cyst with mucinous lining for sure. And I will show you the findings here. It is thick-walled. Actually, that's a very important feature of this entity, this thick wall, but it doesn't have ovarian stroma. And without ovarian stroma, this is clearly not mucinous cystic neoplasm, as we discussed earlier. And the thing is, most of the epithelial lining of the cyst is denuded. And that's why, you know, when you aspirate intraoperatively, we won't see anything. But when we move around, we discover these carcinoma in situ. There was no invasive carcinoma, but there are multiple foci of in situ carcinoma lining the cyst. This explains the high CA, 99 CA, and all the other findings we have. And so this is actually probably the most atypical component of this with carcinoma in situ. Yes, indeed, in the tail of the pancreas, a beautiful neuroendocrine tumor with the monotonous cells, nest, chromogranin, synaptophysin are markers, and it's a low-grade one. Ki67 is very low, so it's good. Very quickly, simple mucinous cyst is a new term that we use for a subset of mucinous, cystic mucinous lesions. By definition, they are non-complex, non-papillary cysts. Often they have thick walls. One of the criteria is that they don't show IPMN cytologically, but they also do not show, as Professor Bengi nicely illustrated, they do not have the cyst by cyst and other radiologic features of IPMNs either. There's no ovarian stroma. That's one of the main criteria. We used to call these things, or it was called mucinous non-neoplastic cyst, which is of course wrong because they often have neoplasia in them. And for some time we called these IPMN, non-papillary IPMNs with low-grade dysplasia, or MCN with atrophic stroma. But finally, it's now in WHO as simple mucinous cyst. Just to cover the differential diagnosis of these mucin-lined cysts, to re-emphasize, if you have ovarian stroma, clearly we have mucinous cystic neoplasm. No ovarian stroma, And if the cyst is larger than 1 centimeter, it has papillae formation, diagnostic of IPMN. And then we have, of course, microscopic incidental forms of mucin-like structures, which we call pannins. So this SMC group they are cysts, they present clinically, they do not have ovarian stroma, they do not have papillae formation, and they do not have classical IPMN intestinal and other cytology. Here's another example of an SMC shown here. They tend to be bilocular, unilocular with thick walls. You see it's not communicating but pushing the main duct here. And as Professor Gürses nicely illustrated, they have distinctive radiology. Nowadays, actually, she's able to tell, I think this is most likely SMC. Now that we made correlative studies, often they can at least put that in their differential diagnosis. Just to illustrate, many of these were called other things previously, IPMNs, MCNs. It won't be wrong to do that, except that ovarian stroma is required for MCN. And here are some examples. High-grade dysplasia is common. And one thing we're discovering, and this is not yet in the literature, is they are not only precancerous, but they often have cancers they are associated with as well. So they are not as simple. I mean, the term simple is in the name, but they're not actually simple. They are precancerous, and they can even lead to true invasive cancer. Actually, when we looked at our databases, 1.5% of PDACs had SMC type lesion in their background.
Şimdi bu hasta öyle kolay gibi düşünüyor ama ben cuma günleri İzmir'e gidiyorum. Sabahtan arabada giderken Volkan abi beni aradı. Bu hastanın ismini söyledi. Bir ay önce biyopsi yapmışım. Sen bunları dedi böyle demişsin. Gürkan arıyor dedi. Bu hasta ne diyelim? Ameliyat etsin mi? Etmesin mi? Dedim abi ben nereden bileyim hastayı? Bir ay önce yapmışım zaten, adını bile hatırlamıyorum hastanın. Ne demişim abi dedim. Sen dedim üstüne demişsin de şöyle demişsin böyle demişsin. Muhtemelen sen de o arada düşünüyordun. Ne diyeyim bu hastaya?
Dediğim gibi o giyotin dedim. What I thought in that case is the guillotine is really on today. I think the head is getting chopped off because we may have made a mistake. Intraoperatively, we are not seeing cancerous cells. Did we overcall? And this is always a concern. Did we overcall the original cytology? Of course, it's really very nerve-wracking because he's going to do total pancreatectomy. I call him. He's not helping at all. He's in the Karacabey area, just driving to Izmir. So that's, it looks nice here now after everything, but it's worse.
There's one more credit to Emre because during the operation, when Ayşe told me it's benign, then I started discussion with your team, and at the end, many ideas were present, but I consulted with Emre. I asked him, I said, there was this significant atypia, and now we have neuroendocrine tumor in the tail. What about the pancreatic head? It says now benign. What are we going to do? Sometimes when you are in the operation, someone outside helps a lot to you to make up your mind. He told me clearly, he said, once there is strong atypia, then there is strong atypia, go for total pancreatectomy, because it was quite difficult, really, making that decision, turning that patient into a diabetic patient. So that credit is also someone outside the operative field who looks briefly and is not compromised by the operation emotions. That's also very important, especially in HPB surgery.
Thank you for sharing this case. We should have all image in MRI or CT before EUS, because EUS and biopsy sometimes make us difficult to evaluation with radiology, right? Thank you.
Edema and hemorrhage after EUS may also interfere with our results, so this is critical.
Also, we have a comment from Professor Bilge. Yeah.
Ben Türkçe ile konuşacağım ama şimdi herkeste bu kadar iyi bir ekip yok. Biz şöyle demeli miyiz acaba? Atipi gördüğümüz kistik lezyonlarda kesin operasyon mu? Yoksa hastaya göre mi karar vermek lazım? İkinci söyleyeceğim de burada hastada kuyrukta bir kitle var ve ne olduğunu bilmiyoruz operasyon öncesi. Ben nöroendokrin tümör kuşkulu başıma 2-3 kez geldi. Sistemik nöroendokrin değerlendirme yapılmasının uygun olacağı kanaatindeyim. Yani hipofizden sürenele kadar bir sürprizle karşılaşmamak için. Teşekkürler.
So two comments. The first one is cyst with ATP. Of course, not every team has all the complete comprehensive approach to these things. Cyst with ATP, should it all be operated or should it be case by case? That's one question. And the second question was, yes, neuroendocrine. If you have a neuroendocrine tumor, should you be screening? Whether preoperatively or postoperatively, we believe in that. In tumor boards, we always mention neuroendocrine tumors can be multifocal, a part of MEN syndrome, and some of them are forwarded to genetic screening. Would you like to answer the ATP thing? I mean, from pathology perspective, since we are the ones who call it, I would say, of course, don't cut everything that we say atypia. But on the other hand, in Europe, unlike in the US, they often, even without, actually, they don't even do EUS in Europe. That's very interesting. They see a cyst, they think it is risky, they just go ahead and resect it. I was shocked to see in recent tumor boards in Europe. We are, I think, closer to US, and I think our way is better to evaluate things. But there will be cases where it will be atypia and nothing, and you're going to have to operate. I don't know the perspective.
Well, we have a very experienced radiology team. They have contact with endoscopic ultrasound. Because Professor Alper clearly thought that this was microcystic cystadenoma, the report came out based on the same day after EUS, MRI came with microcystic cystadenoma. And then after 1 month later, CT performed, and CT repeated by the same radiologist, the similar lesion. Nothing changed in the dimensions and characteristics. So we misdiagnosed as tail lesion without any biopsy, focused on this atypia on the pancreatic head lesion. This tells a lot to us. We have to be sure about, because this is a tragedy during the operation. You sit there while you're planning to perform a Whipple procedure, and then you have to convert it to a total pancreatectomy because of a second tumor. So you have to preclude this happening during the of course, if there is a margin positivity, you can go for total pancreatectomy anytime. But in this case, probably we were having that difficulty because of this unexpected diagnosis of neuroendocrine tumor in the tail. This microcystic cystadenoma, however, all discussions can easily tell it's easily diagnosed. I don't think so. It acts like a solid tumor, as Professor Gürses says. It acts like a solid lesion. When radiology gets support from endoscopic ultrasound, because Professor Alper is so experienced, he can sometimes say, this doesn't look like PDAC, it looks like lymphoma, and we make the biopsy, it comes lymphoma. So that can have an interaction. But in pancreas, 70% of neuroendocrine tumors are non-functional. That's why they're bad prognostic, because they are diagnosed late compared to functional tumors. Should we go for systemic evaluation without any carcinoid syndrome symptoms, without any symptomatic issues might be related to neuroendocrine tumor? I don't think so, because if we are dealing with pancreas, 70% of the lesions are non-functional. But you have to be sure, you have to check the blood tension, you have to ask to the patient about the medical history, anamnesis, any doubt, of course, you have to check everything.
Now we've...
Sorry, I think it was necessary before biopsy from the tail of the pancreas, before surgery, not during surgery. And second, you can protect the total pancreatectomy of the patient. It was not necessary. It is possible to make Whipple plus tail resection. Why total pancreatectomy?
Yeah, that's the difficult part of decision making during the operation. That was not a very small lesion. Then you have resected tail. Then you have resected head. You have the risk of the middle part, the corpus part of the pancreas, and sit there with the risk of leakage of the tail plus the soft pancreas. That was the case. That might be also an alternative strategy.
Before go through with the second case, there's questions from Zoom. Two for gastroenterologist perspective. The first question is the technical question that what is the diameter of the needle for FNB and FNA?
I prefer generally 22 FNB needle for the solid lesions without neuroendocrine. Generally, cystic lesion for the cystic lesion is FNA needle 22.
Okay, and the second question is, in the near future, the sampling practice will change due to the need for much more tissue sampling for NGS analysis or other analysis.
We have to take a lot of biopsy from the especially solid lesions, suspicion of the PDAC. Probably because oncologists want us a lot of tissue for the general therapy of the new smart technologies.
Okay, and for the surgeon's perspective, they're asking for, can we say that for this case, is that overtreatment for performing total pancreatectomy? Is it overtreatment for you for this case, or?
Well, from my perspective, I was there.
You already explained it.
Yeah, it's just to preclude the morbidity related to both sides of the pancreas. It was also an alternative, but I made that choice based on the general health status of the patient.
And if the question is regarding whether to resect small pen nets, we'll have a session, a little bit talk on that in the afternoon. If the person who asked the question can stick around, we'll have interesting discussions there, I'm sure.
Okay, then the questions are okay, and we can now continue with the case 2.
Okay. Now, this is a 39 years old female patient. This patient visited another hospital before coming to our center. The complaints were dyspepsia for the last 6 months and recent darkening of urine, color, and jaundice. So the patient went to another hospital and endoscopic ultrasound and ERCP performed. And during EUS, they didn't detect any mass. ERCP performed, and distal common bile duct was narrow. Biopsy performed, initially evaluated as intraductal neoplasia, a stent placed, and re-evaluation of this biopsy was concluded no malignancy, no neoplasia. So when the patient referred to our center, we planned to perform an endoscopic ultrasound, and Professor Alper performed endoscopic ultrasound. Because of stent, it was hard to evaluate the distal part of the common bile duct. Stent was taken out and then evaluated. Tumor markers were completely normal. Biopsy performed, multiple biopsies performed, and those biopsies didn't reveal any malignancy, but there was a suspicion. This was a very tough case during the follow-up period. First of all, I just wanted to ask Professor Alper about his findings of endoscopic ultrasound.
Volkan abi İngilizce konuştu da ben yine Türkçe konuşuyorum Boğaziçi üzerinde. Biraz önceki vakada da öyle. Bak biraz önce tartıştınız ya niye böyle yaptınız falan diye. Bu vaka da aynı. Yani bizim çıkardığımız 2 vakada böyle hata mı ettik vakalar aslında bunlar. Bu da öyle, bir kadın 38 yaşında. Daha önce başka bir hastanede 2 kez RCP yapılmış. Alınan biyopsilerde de böyle malin de denmemiş, benin de denmemiş. Oradaki gastroenterolog arkadaş da tekrar stent koymuş falan. Sonra bize geldiğinde hastada biz stenti çıkardık. EUS yaptık. hem koledoktan biyopsi aldık, hem fırça histoloji aldık, hem EUS duvardan FMB biyopsi aldık. Ve bu sonuçta biyopsilerde aslında görüntüsü de 4 sanki bir IgG 4 hastalığı gibiydi. Yaşı uyuyor, genel durumu uyuyor. IgG 4'ü 4 civarında, 3,5-4 civarında. Böyle ortada kalmış bir hasta. Yani kıyamıyorsunuz da cerrahiye verelim falan gibi bir hastayı düşünün. Ve bu hastada biz Volkan abi bize dedi ki ya bunda dedi bir şey görmüyorum ama içimde rahat değil dedi. Zaten bu hastayı onun için çıkarttık vakayı. İçimde rahat değil dedi. Biz de ama yine de kendi içgüdülerimize güvenerek hastaya kısa dönem steroid tedavisi, IgG4 gibi kabul ederek başladık. Kısa dönem dediğim normal tedavi 2 yıla kadar uzar. Biz bu hastaya haftalık takip aldık, 30 mg başladık, doz azaltarak ilerledik. 3. hafta sonunda hasta da çok iyi hissediyor kendisini. Ağrısı yok, genel durumu iyi, canavar gibiyim falan diyor. Biz 4. haftada bir kontrol tomografi çektirelim dedik. 1 ay içinde oluyor bunların hepsi.
This is the MRI.
These are T2-weighted coronal images showing you. The one on the right side is showing you moderately, mildly to moderately dilated pancreatic duct. And at the head portion, there is abrupt discontinuation of the pancreatic duct, where there is expansion and heterogeneity at the head of the pancreas, excuse me. And in the first image, you can see dilated, mild to moderately dilated common bile duct. Although I cannot see the pancreatic duct inside the lesion area, I can see the common bile duct penetrating the pancreas. So, you know, maybe there is the duct penetrating sign. If we see the duct inside the lesion, the pancreatic duct, it's probably pancreatitis, chronic pancreatitis. But if we don't see any duct, this is probably malignancy. I can see one of the ducts inside the lesion and the other duct is not seen inside the lesion. So again, I'm in between malignancy and focal pancreatitis.
Emre hocam, endoskopik ultrason bulgularınızı
endoskopik ultrasonu buraya koyamadık. O dönemki fotoğraflarımız kayıp Medgate'te. Şu aynı bunun gibi görüyoruz. Çok kalın bir duvar. Ampulladan başlayıp yukarıya kadar gidiyor. Şeye kadar, ana kanal düzeyine kadar neredeyse ayrıma kadar. Her duvar sirküler, her yerde kalın. Yaklaşık 4 milimetre kalınlığında bir duvar. Hipoekoik, yani sanki böyle enflamatuar bir duvar gibi görünüyor. IgG4'te de böyle görüyoruz. Ve içinde stent var. Sorunumuz burada zaten. Bu stent yaklaşık 2 aydır içinde. 2 ay stent. Ve bu stent burada enflamasyon mu yaptı? En büyük sorunumuz bu. Yoksa gerçekten bu enflamatuar bir duvar mı? Yani bizim bu hastada çıkarmamızın sebebi aslında yani kesin tanı konmadan bir iş yaptığımızda, özellikle stentleme yaptığımızda bir sonraki stepte sorun yaşamaya başlıyoruz. Enflamasyondan dolayı.
Okay, just a brief endoscopic ultrasound findings. It was a thickened wall. Because of previous ERCP stent, the wall was ödematous, and not only in the intrapancreatic portion, it was going up almost close to the hilar plate, and there was no irregularity within the bile duct, just 4 millimeter thickened wall, and the stent was removed to perform a biopsy and evaluate in the endoscopic ultrasound. What Professor Alper told was nothing correlated with a significant malignancy. Some typical findings of IgG4.
Actually, Professor Alper called me to the endoscopy suite and we looked at it together. Of course, I'm not an endoscopist, but he beautifully illustrated to me that this was a very even, a tube-like structure that's going proximally for several centimeters. So you will see this turned out to be cancer. And it's one of those cancers that really constrictively forms a very even tube. And it just goes without any irregularities, without forming nodularities. It was so dramatic, so interesting that, and when I saw that, actually, I became even less convinced that could be carcinoma. That kind of pulled me down from making a carcinoma diagnosis, because it's just so even and almost cholangitis pattern.
There is no diffusion restriction at the head portion of the pancreas, so it is not possible to differentiate between mass lesion and focal pancreatitis. Again, you can see the moderately dilated pancreatic duct and common bile duct and wall thickening. It's like millimetric wall thickening, maybe due to stent or due to some inflammation. It's hard to differentiate. And there's a stent that you can see inside the common bile duct on the MRCP image.
We have a question from the audience.
Diagnosis, you consider through pancreatitis, maybe stent-related pancreatitis.
Well, maybe chronic pancreatitis, pancreatitis or IgG.
We are talking about the novel CT after steroid treatments. After steroid treatments,
I didn't show it yet.
okay,
Yes.
okay.
Okay.
Cytology.
Okay, actually, it was two examples. First belongs to the common bile duct wall aspiration, which is totally benign, and those slides belong to the brush cytology. And which we can see in here is that we have in here benign cells, but in near of them we have a highly atypical cells in here with a very pleomorphic. Those cells are very pleomorphic, and when we look in here, we have the benign cells in here and those highly atypical cells. Because of the patient's history of the stent, and I didn't show you, but there are a lot of neutrophils in here, and the patient has a stent, and the radiological images is not consistent with the malignancy. And here we are seeing those highly atypical cells. Even in my presentation, I told you that even with the two cells we call malignancy, but in this case, because of those inflammatory processes, we are not able to call this directly adenocarcinoma. But we write our report that this is highly suspicious for adenocarcinoma, but those cells are very few, and there are a lot of reactive cells, which, for example, like that. Because of those reactive cells, we are not able to give a permanent adenocarcinoma diagnosis. And at the same time, we have a biopsy, which came from the outside institute.
Yeah, this case really, is close to our hearts because we really thought this was going to turn out to be adenocarcinoma, but the biopsy findings, cytology findings, they just were not enough for us to pull the trigger. That's the bottom line. At some point, we were almost going to call it straight adenocarcinoma, and we backed out, and we shouldn't have. You see these changes here in the outside biopsy performed. In this outside biopsy, there were also some fairly atypical clusters, but it was so degenerated, crushed, that we were not able to pull the trigger in the end. But we were very close to it. I wish we had called it, then the treatment would have started earlier. But we want to show this case. That's the nature of the business. We cannot, unfortunately, be confidently calling cancers readily in many cases. And later biopsy showed much more convincing adenocarcinoma, unfortunately. As you see here, we have the normal units. We have the normal glandular elements in the ampulodural mucosa, and then we have clear-cut adenocarcinoma with pleomorphism, infiltrative. When you have something like this, of course, it becomes very straightforward, but we didn't have it in the initial biopsies. I would like to use this case very quickly. Bile duct is very different than pancreas. In the pancreas, because it's a solid organ, because there are not ulceration, usually there's not that kind of inflammatory injury to the epithelium. Pancreas, we have 90-95% accuracy rates nowadays, but bile ducts, we're still struggling. Sensitivity is 44%, which is very low. And this is our study where we know the cases proved to be cancer, and the bile duct brushings we couldn't call, and were mostly. And this also illustrates, this is several pathologists, about 20% of the cases, this is United States, 20% of the cases get to the atypical suspicious gray zone diagnosis. This, again, the nature of the business. One thing, though, what we did is we took out those
real life cases, picked out 60 of them and gave it to the same group of pathologists and asked them to give diagnosis, the sensitivity jumped up to 66% from 44%. That's actually proving the point that when the pathologists have the weight of that diagnosis and causing chemotherapy or a major surgery, they are reluctant to call it adenocarcinoma. They kind of tune it down and call it atypical, suspicious. That's again the reality of our business. But when you take out that real life pressure and put it in the study setting, it's not perfect, but there's significant improvement in sensitivity. We did one other step of a study. We did bile duct brushings ourselves on pancreatectomy specimens. We smeared and we circulated with our colleagues, the same group of colleagues. Of course, this is a static specimen on a Whipple. We are doing it nicely, brushing, and we are looking at the corresponding histology. So that's as good as you get from a real perfect matching, if you will. And then the sensitivity jumps up to 86%, because of course you get more tissue, better specimens, but it's still not perfect. Again, still you can miss that. And we interpreted these results as from 66 to 86% jump is probably something maybe operators, meaning endoscopists, can get better tissue, and we might be able to call it. But there was also this fact that those of us who do pancreatobiliary cytology routinely were actually in the 95% range in this imitation bile duct brushings from Whipples, whereas other pathologists still was in the 80s. So there's room for pathologists to learn. It's not easy to get experience in these things because these are rare specimens too. Something you see every day, you get very good at. Something you see once every 3 months, it's hard for the pathologist to get the expertise. So I just want to illustrate bile duct brushings and bile duct biopsies in general remain a very problematic specimen for all of us.
Yep. Final.
Now you see, unfortunately, the new images, CT images. Now there are some faint, subtle lesions, hypodense lesions in the liver. They are hard to differentiate, but they were better seen on our PAC screen. They were new. They didn't exist on the previous MRI. And when you look at their density, they are not like abscesses. So these are metastases. You can again see pancreatic ductal dilatation here, and the stent is seen. On the MRI, the metastases were confirmed. There were a lot of metastases, the largest one being 1 centimeter.
This one is the ERCP stenting, low insertion cystic duct. And on the right side, you see the metallic stent for the medical oncologic treatment period. So this was a sad case. I still remember the day when Professor Alper was performing EUS. I remember the thick distal bile duct wall, and I remember all those discussions with Professor Adsay. Even after this case, we have many discussions because of this lady. Professor Adsay carrying the guillotine on his neck, and many more times saved patient's life. Someone has to say something at some point, but it's so difficult, especially in these cases. The samples are not enough because of all those inflammation. The decision to go for operation is not that easy. For this patient, after 3 weeks, we had this metastasis, which clearly shows us that if we decided to go for operation, probably that would bring us early postoperative extensive disease. But in other patients, for saving them, possibly diagnosing as early as we can, we have to be careful, but experience counts a lot, as Professor Adsay showed us. One
aspect of this case, I think there was also a little bit of response with steroid. We see this because in autoimmune pancreatitis, presumed to be autoimmune pancreatitis cases that are adenocarcinomas with steroid, adenocarcinomas also shrink because, as we illustrated, PDACs have a lot of fibrosis and inflammation, and steroids leads to a little bit of a shrinkage, but that's very long, short lasting, and then Actually, I don't know why, but then the patients come back with disseminated disease after that.
I would like to thank you for your excellent discussion. Now we go on with the how I do it session. The endoscopic and cytopathologic techniques video session. Professor Emrah Alper and Professor Pınar Fırat.
Well, actually, we can maybe skip this session because we have several cases. Well, life is not always that difficult. Maybe it can be a relief for you because we brought just ordinary cases, which are not terribly difficult to diagnose and terribly difficult to treat. And we're going to talk about only the endoscopy and the cytology of those cases, just ordinary cases. Would you like us to continue or just leave them to the end of the very end of the day?
No, please go on. Yeah.
Okay, so we have very limited time. Okay, you start, please, with they're not difficult, so maybe it's good to talk about that we are managing most of those cases, and I'll try to give, or I'll try to show how cytopathology is approaching those slides. In most of those cases, we're able to go to the diagnosis. But first of all, even though Emrah said that it's not possible not to obtain a material after 15 times, but sometimes it is possible. I mean, the ability of a cytopathologist or a cytopathologic specimen to diagnose a mass starts with the operator. So first, the material should be taken from this lesion, and it's not that easy always. Even if you see your needle within the lesion, it's not so easy to aspirate them. So the technique details is with Professor Alper. So please.
We prepared the cases with Dr. Fırat. The interesting cases for me because, for example, I saw PANNET, or I wrote the report PANNET, but lymph node, etc. and accessory plan.
So I mean, we are as a team so lucky that we are working with a very good endoscopist. I mean, he's really giving us a very nice material. Unless you see enough amount of cells and a high quality smear, it's not possible to be sure about the diagnosis. So if you have in your series a lot of inadequate cases, a lot of atypical cases, a lot of suspicious for malignancy cases, then please start to question your team from the very beginning, the operator, then the preparation, and then the interpretation.
You can see here that the lesion is head of the pancreas. The view of the lesion, I think that it's adenocarcinoma because there is no regular margin of the lesion, and tissue darkening is dark the other part of the pancreas. I have taken the biopsy from the FNA biopsy probably from the lesion, and after that.
Continue.
Mm-hmm.
Yes, those are not very recent cases. Well, the first case is a clear-cut adenocarcinoma from my pathology colleagues. Well, those are all neoplastic cells, so crowded, and also the nuclear atypia is clearly here. There's some necrosis in the background. No doubt that this is an adenocarcinoma. And we've got, as you see, plenty of cells, and they are nicely smeared. We can see all the nuclear details. Okay, it's done.
It's easy case for
easy case.
us.
So that's for the start.
Yes, endoscopist and gastroenterologist.
Exactly. Those are the cases. I mean, they come. How to say? I mean, most of our cases are of that kind. So this is another case. This is a very typical PDAC. Morphologically, I don't want to go into detail, but once we come across those drunken honeycombs with those lacy cytoplasm and with those nuclear pleomorphism, and if we're in the pancreas, even if we're out of the pancreas, we should suspect that the primary is in the pancreas. So this is a typical picture. So the second case.
Yes.
Okay, sorry.
The other case, we can see here the lesion, the margin of is regular. And there are a lot of vascular collaterals near of the lesion. I took a biopsy from, in this area, and after that.
Okay. We, again, has many cells, and you can even think that because the tissue fragment will going to be so heavy on macroscopic examination, you might think that, well, that could be a tumor, but no, this is only surface epithelium. The needle is passing through the stomach, and stomach is the main mimicker.
Our problem.
Yes. We should know this. It's better to know it because not the duodenal epithelium. It's rather easy to recognize it because we've got those nice goblet cells within those columnar epithelial cells. So it's easy to recognize the duodenal epithelium. However, stomach may mimic pancreatic adenocarcinoma. And if it's not very nicely smeared, may cause some problems in interpretation. Look at this. This is also a nice monolayer, kind of honeycombing, maybe coming from the pancreas itself. These are not looking really ugly. Still, for me, they are benign cells. We continue. Oh, this is from the pancreatic parenchyma. Nice acinar cells, clearly benign from the pancreas. And okay, now those are the acinar cells. Maybe some benign cells. And what about this? This looks very much like stomach epithelium, and I know that we pass through stomach. Well, what about this? It's a little bit more crowded, but maybe atypical. That's the most I can go. But when I come to this area, and if I have the chance to compare with a nice stomach epithelium, those atypical cells, and if I realize that they are completely different cytomorphologically, then I'm on the safe side. But the specimen might be composed of only of those cells. Some, still I don't know from which part is coming this tissue fragment, either from the surface epithelium or the tumor itself. I really don't know, but I know that this patient has a tumor. It's here. Those are all benign cells, and it's clearly pancreatic PDAC. And once more, the nuclear details are there. So it's again a pancreatic ductal adenocarcinoma. However, those cells might be few in between the benign cells. They may cause confusion. The tumor might be well differentiated. So you have to stay in between, and you need a nice material. You need those comparisons. So that's the tissue block. You see that the tumor is here within the pancreatic parenchyma. Again, here, quite close to the pancreas. So our aspiration or our tissue cores have them both. And we can stay in between those if we don't have nice cells.
Easy for the technician,
and the third
for pathologist. You can see here that the other case, probably a little lesion. There is a diameter of the lesion 6 millimeters.
Very small.
Very small. In your, yes. And I take a biopsy from middle of the lesion, and that.
Yeah, well, it's a tiny lesion. It's difficult to obtain cells from this tiny lesion, of course, and that's all we have. Like the previous case, which is discussed in detail. Well, they are clearly abnormal. And if you've got many of those cells, I'm going to call it adenocarcinoma for sure, but I'm just staying a bit nervous. I'm not sure. It's a tiny lesion. The patient will receive a pancreatectomy, and you know, the number of cells is not even 100. So even if they look very much atypical to me, even if they look very malignant to me, the diagnosis of this case was suspicious for malignancy. So we have to stay somewhere. But of course, we called it is highly suspicious, and all those team discussions are done, and finally it is resected. The lesion is here. And it is adenocarcinoma, a very tiny adenocarcinoma. So why I have showed those cases, we have showed those cases, because we have to stay somewhere. Most of our cases are directly malignant, and most of them are PDACs or neuroendocrine tumors, the easy part of it. Some are clearly benign and fits with the clinic, it's okay. Some are cystic. For the cystic lesions, we'll look at the cyst flute if we don't have a solid part of it. Then we call if we have epithelial cells, even if they have high grade or low grade changes. So we talk about them. But for the rest, I mean, it's impossible to delete the atypical cases and suspicious for malignancy cases. As you have seen in our reports, we give our descriptions, our own descriptions. Because we are a team, we are able to discuss with each other. So maybe we understand each other nicely. But of course, there are nice standard reporting systems. And this is the recent one done by WHO. So of course, we try to minimize suspicious for malignancy and atypical. Those are original pictures from the document. However, they exist.
The patient was performed Whipple procedure for the malignancy. In the follow-up period,
we are exiting time.
Yeah.
In the follow-up period, it's about 2 years later, the patient had a nux pancreatic adenocarcinoma in remnant pancreas parenchyma, and probably I'm not sure that the patient died with a pancreas adenocarcinoma. Nux pancreas adenocarcinoma or secondary.
Yeah. I apologize for taking some more time.
But we should close a leave session and then.
I know, but well, the more interesting cases are the following. That's why I suggested to leave them all to the end. Well, okay, just quickly, even if it looks like a neuroendocrine tumor, this is a common situation. It's a lymph node. It's a nice lymph node, and that's all. It's over. No neuroendocrine cells here. It's totally a lymph node. Another case. At least we should talk about it.
We can divide it two and
okay,
go
let's continue later on.
It's a
good suggestion.
Yeah.
Okay, if you like.
Okay, thank you for your nice
any questions on that adenocarcinoma site? We're going to continue with the neuroendocrine part.
There's a question from Zoom that they're asking for if it changed your practice to put a stent in the bile duct. It changed the quality of the specimen or?
Well, the inflammation it causes might give some extra anxiety to us, at least, because it may cause reactive changes in the epithelium. And of course, as pathologists, we become more worried about whether it's reactive or malignant. It makes it more difficult. We are always one step backwards when we have such a triggering agent. But basically, the cells, if you obtain nice cells and if you prepare them nicely, the cytologic details do not change. Okay. Just becomes difficult to interpret.
Thank you. Now I am closing the morning session, and we will go.
Thank you.
We will be online 1 hour later, and herkes sahneye davet ediyoruz fotoğraf için.